Welcome to GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis. Lung cancer, think A to G. Our specialist is Dr. Matthew Evison. A. Appetite loss.
There are the more systemic symptoms, weight loss, fatigue, appetite loss, that we have to be alert to as a potential presenting symptom.
B. Blood tests.
There are so many generic markers of an inflammatory picture. We see elevated ferritin is an acute phase response. That's often done in the anemia workup. I know specifically looking for iron deficiency, but that inflammatory pattern that sees the platelets go up, a hemoglobin drop, an albumin drop, they are all markers of acute phase inflammation.
C. Cough.
Hemoptysis is the one symptom that has a positive correlation with a diagnosis of lung cancer, and it's for that reason that NICE pick out that symptom as warranting direct referral. And that, I think, that message has really has been taken on by our communities in that it's a very visual symptom. It often triggers a review with a healthcare professional, often triggers referral, rightly so. Reality is there's a huge number of other causes of hemoptysis, but always needs investigating. The other symptoms are much more generalised around cough, breathlessness and chest pain, which obviously have a very wide differential diagnosis, and equally are often symptoms we know our patients place less emphasis on than something like hemoptysis or blood in the stool, which we know is another really important one that triggers consultations. Cough, breathlessness, being so common, I think there's a huge message for us to get out there around them needing checking out because they are a common presenting symptom of lung cancer.
D. Don't forget never smokers.
Less than 100 cigarettes in their lifetime, lifelong non-smoker. And when you use that definition, there are about 6,000 patients, people that die of non-smoking lung cancer every year in the UK. So it's becoming really clear that this is not uncommon, but under-recognised. If you take it as an entity on its own, it's the 8th commonest cause of cancer death in the UK, the 7th worldwide. I think the same principles apply that some of which we've covered already, which is very low thresholds for investigating persistent symptoms with a chest X-ray. And when that gut instinct, which we know is one of the most powerful predictors of a cancer diagnosis, is the GP's gut instinct that something is wrong. When that is there, we should not be reassured by a lack of risk in a non-smoking history. Persistent symptoms can rightly and appropriately be referred on lung cancer pathways to exclude that as a diagnosis.
E. Early diagnosis.
There's been a really powerful social media movement from patient advocates around the line that if you have lungs, you can get lung cancer, which is absolutely right. Anybody can get lung cancer. And early diagnosis becomes critically important.
F. False negative rate of chest X-rays.
25% of lung cancers will present with a normal chest X-ray. So the sensitivity is around 75%, and there is a lot of data around that supports that general figure. So we absolutely want to see patients where there is a suspicion of lung cancer despite a normal chest X-ray. Very much want to see and encourage those referrals.
G. Greater Manchester referral PROFORMA.
There are 2 routes into the cancer pathway. One is you have a chest X-ray and it's upgraded. And it's abnormal, or the other is a direct referral on the pathway with or without an X-ray, could be normal. I think the gold standard is that if a patient attends for an X-ray that is reported as suspicious of cancer, that goes directly to the hospital cancer teams. It's upgraded, activated immediately for them to be, some places have systems in place for same-day CT scanning as soon as that's identified, but with a responsibility on the hospital team to activate that. That's the gold standard. It's what's in the National Optimal Lung Cancer Pathway, which states we've got 3 days from that X-ray to get that person into a CT scanner. And the direct referral, we want to be, as I've said already, encouraging, making sure that that direct referrals remain always an open system to where there is a suspicion of lung cancer, regardless of an X-ray, whether it's done or whether it's not done. Which should, and our process is any of those referrals go directly to a CT scan. We've always had the view, if a GP feels there is a suspicion of lung cancer, and when we get a referral, we've never seen that person. So the person that has seen them feels there's a suspicion, that has to have a CT, and they will go directly to a CT scan. There can be issues around blood tests and renal function for contrast for CTs. We get around that with a point of test. So anyone can have a finger prick testing for their renal function on arrival, so it doesn't delay anything. There is some variability around the region, which we have the responsibility of trying to ensure there is equity of access to all of these things across the region.
Think A to G. A. Appetite loss. B. Blood tests. C. Cough. D. Don't forget never smokers. E. Early diagnosis. F. False negative rate of chest X-rays. G. Greater Manchester referral PROFORMA. GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.